Today we're going to be discussing hospice. Do you all have any familiarity with the subject?
I mean, you hear a little bit
Yeah,
about it.
I have no firsthand experience. I've known people who've had their parents in it, but as far as me having a relative in it.
Well, this will be very helpful should you ever need it, this in-service.
I'm always thinking like hospice, you had to go there, but then I'm finding like...
They come to you.
Yes, it's a lovely service.
Coming in and out. And, But is that a state by state?
It really is determined by the medical director of the hospice, and I'll get into how that happens. But the concept of hospice came from the medieval times because the church and some religious orders in the medieval times had large places where they had cots, kind of like the shelter that we know of today, and it was for like people who were passing by and were tired and needed comfort. It was for the dying, the wounded soldiers, and that kind of thing. And the people who needed comfort and care would come to these, they called them hostels back then. I think they still call...
Oh, that's what they call you.
Yeah.
Like a hotel.
Right. But back then in medieval times it was called hostels, and it's for people who really were in distress and needed help, and the church and the religious communities, the sisters would take care of them. So that was the concept of hospice. In contemporary times, the concept is still the concept of care, but it's not in a place so much as caring for the individual. And hospice emphasizes palliative care rather than medical treatment, curative treatment. When you are referred to hospice, it is typically thought by the medical physician, either your primary care physician, that you have 6 months or less to live. That's not always true as it comes out, but to enter hospice, there are certain guidelines if you're a Medicare patient that you have to meet, and one of those is a certified statement from your physician that you have a life-limited illness, what we call terminal illness, that they do not expect the patient to live beyond 6 months. The hospice team, when there's a referral from the doctor or the family, when there is evidence that you have a life-limited illness, the physician or the family approaches the subject, is hospice really appropriate for the person? And so they'll make a referral to hospice. There's 2 hospices in Tallahassee, the Big Bend and Covenant, and the family would choose which one. I always suggest to people who contact me that you go to both and talk to both, because hospices are not the same. They both have the concept of care, but the quality and quantity of services differs from hospice to hospice. So I always advise the family, you go there and you look and talk with somebody and see what you think, and then you would choose one of the 2 hospices in town or wherever you are. But I think it's a good idea to investigate the services. Anyway, what happens when you have a referral to hospice is the nurse comes and she does an assessment of the patient. And the first thing she does is she'll call the primary care physician and say, do you think that Mr. Smith is appropriate for hospice care? They usually have to have the doctor's okay. If there's a discrepancy between what the primary care physician has said, then there's always an option to go to the medical director of a hospice, who's a medical doctor, and he can also give an order to have hospice care. But the thing about hospice that folks don't realize is because it's palliative care, which means pain management and not cure, you have to come to a decision that the diagnosis of the patient is such that they're going to die. There's no cure. Because with hospice, when you're in hospice services, you don't get aggressive treatment. It's to prepare the person to die. It's a completely different thing than the medical module of being in a hospital. In fact, if you should break your leg and you're in hospice, then you'll have to call hospice because they'll have to terminate your hospice status until you get your surgery and then come back and be readmitted to hospice. That's just how Medicare works. The idea of hospice is palliative care, which is pain management. And that's what they specialize in. The medical director is in constant contact with the nurse who comes to the home, and he is the one who prescribes the pain medicine that's needed, or what they call symptom management, to prevent people from being in pain. Now, I've often been asked, does hospice hasten death? And the answer is no. They do nothing to hasten death, but their job is to make it more palatable in terms of the pain. The nurse will come and do an evaluation of the patient. It is the law in Florida and most states that the decision to have hospice is really the decision of the patient. If the patient doesn't want it and they're cognitively intact, the family cannot impose hospice on the patient. They have to sign the consent forms, just like when you go to the hospital and you have to sign the consent forms to be treated. It's very much like that. And then, if you're a Medicare patient and you sign that, you have a statement from Medicare saying that if you're in hospice, then you do not qualify for other services that would be a curative thing for your illness. So going into hospice, they make sure that the patient and the family knows that this is a palliative care program and not a curative. So they do treat for UTIs and infections and fevers and that kind of thing. But for example, if you had, like my husband and I, in the past 15 years, have a mission of taking elderly poor who are dying into our homes, who have no family and they don't want to die alone. We take them into our home that they can have a peaceful death. And that was as recent as April of this year. But this particular man was a homeless man from the shelter who we had seen about for about 2 years. He had throat cancer. My point is, if, for example, they said, well, if there's a tumor growing and let's try to remove it surgically, he could not have that removed in hospice. But he was already declared dying and terminally ill, and so if he decided that he wanted to have elective surgery of getting the bigger tumor out, he could not do that and be in hospice. So that's really important that people know the difference there.
Can they sign themselves? You said they could sign themselves out of it.
Mm-hmm. Mm-hmm. Yeah.
I have a question, and it came up with my grandfather, and my aunt said something like you could get into hospice not just because you're within 6 months of death, but for really old people.
No.
Like in the 90s.
No.
That's not
Hospice affirms life, and they regard dying as a natural process, but according to the Medicare guidelines, you have to have a life-limited diagnosis illness to get in.
It can't just be extreme age.
But like a 90-year-old may have chronic heart disease or something like that. 90% of the hospice patients are cancer patients, but then they do accept any diagnosis that's life-limited. Old age is not considered an illness. It's kind of like a progression of, life. So if you are elderly and don't have a life-limited diagnosis, you can't go to hospice according to the Medicare guidelines.
Now, do you have to be in Medicare? Like, is this a Medicare program?
You don't have to be in Medicare. Most private insurance, like our daughter has 4th stage metastatic cancer. You don't have to be in you don't have to have Medicare coverage, and most insurance companies do cover hospice. If by chance a person has no coverage, say for example they're younger than 65, and they're in their 40s and they have been diagnosed as terminally ill, and the nurse finds out from the insurance coverage they don't have coverage for hospice, then the only option in Tallahassee would be you would go to Big Bend Hospice, be admitted there, and they take fundraising monies to pay for the hospice. Fundraising, and they have foundation grants and that kind of thing that pays for people who cannot afford it. I don't know that Covenant has that, but typically if there is no insurance coverage, and there usually is for most people, even who have private insurance, if there is no coverage, then there are grants and foundations that will pay for it. Typically, in our experience in taking care of a dozen people who are very poor, the Medicaid pays for it in 47 states. I don't know which 3 states don't allow Medicaid to pay for hospice, but in our state, Medicare and Medicaid both pay for hospice. And I've never known anyone to be rejected for hospice services that were not covered. And most of our people have been the elderly. There are some children, who get cancer and are terminal, and usually their costs are covered in their parents' coverage. But that's why it's good for families to go to the hospice place and have these kind of questions, because you want to make sure you're covered, or if you're not covered, there's funds that will help cover the hospice. Medicare pays for all the expenses of hospice, not only the care. The nurse comes once a week in the beginning. As things progress, they're on call 24 hours a day, and if you have an incident that happens, maybe they develop a sudden fever or something, they will come out. If you call them, the nurse from hospice will come out, but typically it's just once a week. And they do blood pressure, they take the vital signs, they look at the skin integrity, that kind of thing, and they really are the voice of the medical concerns to the doctor. They report to the doctor every week about this. Like I say, they will come. They're on call 24 hours a day, but they only come once a week unless you need it, and that's usually an hour. That's also Medicare guidelines.
The visit is an hour? They come once a week for an hour? Okay.
Can you clarify something? Now you're saying, say you're in hospice and then you get a bed sore. Is that treated?
Yes,
okay.
It is. Skin integrity is very important because as a person progresses, they become bedridden.
No, because it's like I'm thinking in my mind, well, you're going to die anyways. Why should we?
Oh no, because that's painful, and the goal of hospice is to be pain-free.
Okay, I was thinking I'll just give you more pain medicine.
No, they treat it. They dress the wound, and that's the other thing. They buy all the supplies like the wound care, salve, and that kind of thing. Hospice pays for the medical care, the medications, and they pay for the equipment that's needed. The nurse will assess what kind of equipment is needed. Usually it's a bedside commode, a wheelchair, just depending on the level of disability of the patient. So there's, excuse me?
Could be oxygen tanks too.
Yep.
So are you
Anything is
allowed to
necessary.
get flu shots and pneumonia shots
Yes.
when you're in?
Yes, because the respiratory problem is very painful for the patient. So they will give antibiotics, that kind of thing. They just cannot have medical intervention that requires hospitalization.
Aggressive.
The aggressive treatment is a no-no in the coverage.
Yeah.
And they make sure that the patient and the family know that. Now, if the patient becomes better and becomes in remission, you can be discharged from hospice and, get aggressive treatment. Or if the person is in remission and then a year or two down the road they are sinking again, then you can be readmitted into hospice and the insurance will pay for that.
What about, like, you said most of them are cancer, so did they still get their cancer medications, or that's?
They do. They do. It's been our experience in treating cancer patients is that the oncologist is saying, by the time hospice is available, they're saying this cancer treatment is no longer working.
Okay.
But if they're in contact with the oncologist too, and if something a consultation is made for a medication, they will buy that as it relates to the illness. But usually by the time you're in hospice, the treatment is determined to be ineffective.
Mm-hmm.
My father has got the prostate cancer and he's doing chemotherapy.
Mm-hmm.
And one of the things I found out through my research is, okay, he's doing the chemotherapy, but not only does it help, with the cancer, it actually helps with pain too.
It does. It does.
So it's a pain reliever,
Well, the oncologist, who is the doctor of the patient, will often recommend certain pain medicines. He'll talk to the medical director of hospice, and there will be some pain medicine administered that way. Remember that the goal of hospice is to make them as pain-free as possible. Now, I've often been asked, will the pain medicine make them comatose or not alert? And generally, that's not true until the end, when they lose consciousness or lose awareness. But the pain medicine that they're giving can make you sleepy like anybody else, but they're very careful not to sedate to the point that the person has lost the ability to be alert. Now, I'm going to talk about the process of dying in a minute, because there comes a time when the patient does sleep more and becomes non-responsive, oftentimes, and that kind of thing. But typically the pain medicine that they give is not something that makes them unresponsive or not alert.
How long does it take to get on hospice?
24 hours.
Okay, so once you make the decision, 24 hours.
Well, if the doctor agrees.
The doctor agrees.
If the doctor agrees. The other thing they look at is the family environment. The question that I get asked is, how many people does it take, if you're going to remain in your home, how many people does it take to take care of a patient in the home? Again, each patient has an individual program plan, and that's part of it. Early on, a person does not need to have continuous someone take care of them. Like, we have had patients come to our house who could come to our porch and go back to their bedroom, and they could come to the table to eat and that kind of thing. But because of my fear of responsibility, my dedication to responsibility, we've never left any of our patients alone. But what I'm saying is that early on, the family could, go grocery shopping and then leave the patient alone. But as they get worse, sicker, then hospice will say, we need someone continuously with this person, and usually family does that. They do have volunteers who will come into the home for 2 hours a week or twice a week, and they will give the family respite care in terms of, you want to go get your hair done or you want to go grocery shopping, here's a volunteer who's been trained, who'll stay with the dying person while the family gets a little bit of respite. The other thing is that Medicare does provide a week a year of respite care where the person can go to the hospice house and give the family relief. That is 7 days that Medicare will pay for. Now, Covenant does not have a hospice house, but Big Bend does, and I think it's like a 12-bed facility, very lovely.
It's right there on it's like right here. I mean, that one hospice, it's sort of behind the dermatologists and all that.
That's Big Ben.
Okay.
That's big. And behind that office is a lovely, lovely, peaceful, beautiful facility for people to come who cannot be managed at home or the family needs respite care. Now, if you've been with caregivers, you know it's a very exhausting thing, 24 hours a day, 7 days a week. And so families are encouraged to take advantage of that 7-day respite when they just really need that. The other thing is that when a person is dying and they're considered imminent, which means death is very soon to come, the nurses, a nurse will be at your home 24 hours for 3 days. So that's allowed too, but that's when you're declared imminent. And we can usually tell through the breathing pattern. I'll get into that in a minute, but when the person is generally bedridden and the breathing is very shallow and very quick, and they stop breathing from 5 to 30 seconds, then they have the quick breath again, and sometimes up to a minute they're not breathing. That's an indication, and the nurses, teach the family what to expect. That's an indication that death is very, very close. The biggest fear of the dying is to die alone, and so that's why hospice spends a lot of time with the family to teach them what not the warning signs are, but what the natural signs of dying are. It's very important once it is determined the person is dying, is to have a conversation with the loved one. Where do you want to die? Who do you want to be there? What pets do you want? What family do you want? While the person is able to make those decisions, and that causes less stress when the time comes early on when a person is considered a hospice patient. We need to have these conversations so that we can honor where do you want to be buried, that kind of thing. It's very painful for the family to do this, but you will find that once you have this conversation with your loved one, it's less stress for them and for you because you have a plan. And the important thing of a dying person is involve them in decisions and choices as much as you can. But early on, you do want to ask those questions, as painful as it is, and get that out of the way. And as I say, it's a relief to the dying person and to the family that we don't have to, talk about this again. We've got your plan. Yes.
Will hospice come into a facility like?
Yes. It absolutely.
Or even the hospital.
In the hospital.
Or even come to the hospital if the person isn't hospitalized and they're going to come to the hospital.
Every hospital has hospice beds. Every nursing home has hospice beds. If you are in assisted living, it's like you being in your own home, and so hospice will come to assisted living. But they don't really, there's no place where hospice can't go. It's wherever the person is. And that's what I was saying. The hospice is a plan of care for not the place, but where you are. If you need a bed at the hospice house, if you're imminent and you have to have, the family can't take care of you, they either call us to bring them home or they go to the hospice house. But every facility has hospice beds. Nursing homes have an allotment of hospice beds, and each hospital has an allotment of hospice beds. And a lot of times the family just cannot take care of the person. And if the family cannot take care of the person, there are other options in Tallahassee, well, all over.
Yeah. Why would, say if they're in a nursing home, why would they have to have a hospice bed at a nursing home rather than just stay in the same room?
Oh, well, it is the same room, but what we're saying is like the nursing homes usually have 4 to 6 slots of hospice slots. You don't have to move to a hospice unit, although there are hospice units. But hospice, if someone is in a nursing home and they're declared to be needing hospice services, the patient doesn't have to move to another room. The hospice will come to that person. That's considered one slot.
Well, it's a good way to become educated rather than come to a presentation by you. Because my family, you know, got different personalities, not everybody agrees, but has the, you know, and I like my parents to hear this, but it's like my sister, who's their caregiver, doesn't want anyone involved. Anyone brought in from the, you know, the quote outside.
We run into that a lot. They don't want outside interference, and a lot of denial goes on in families when you reach this stage. The best way, I don't know what to tell you except that it might help them to visit a hospice facility. There's much online about hospice services. If they don't want that interaction, but it's a shame because the interaction can put the family at peace.
Yeah, because I know we were looking at it when my grandparents were dying, and my aunt was bringing it up, and you know, with my mom and my sister, they're like, well, we don't want any, you know, so that was it.
They don't want people coming in and out.
Coming in from the outside, you know, we can deal with it, rather than this being a help and helping us through this.
But what they don't realize is that it's such an exhausting process to take care of someone 24 hours a day, 7 days a week. And you get the support from hospice as a family, and you know what to expect. Nothing is worse than going into a home and having a dying person there who needs services like counseling and social worker and those kind of things, and the family is still in denial, and the dying person needs to be comforted, and they need to know what's going on. That's part of the presentation I have today, is that when a person is dying, you need to be very mindful that most of them fear dying alone. And it's the social worker part of counseling is to counsel the family on what to do. For example, one of the most painful things is when mom and dad stop eating and drinking, and the daughter wants to force the food, you know, and they want to force the water and that kind of thing. If they don't have hospice in there, they don't know that part of that dying process is that it's very painful to drink and eat, and the body cannot process the food or the drink. And do not force drink and food on a dying person. It makes them it's very painful, and it makes it worse than it needs to be. If a family did not know that, and most people don't know the process of dying, hospice is the advantage to your family of telling you about the processes of dying and how the body breaks down. But the most painful thing is when a family who's not familiar with the dying process forces food or water on their loved one, and they don't realize that that is excruciating painful. Even if the patient appears comatose, they can feel pain. The other thing that families may not know if they don't have hospice, and I'm telling you, hospice is an education tool for the family and for the patient. You don't talk about the patient in front of the patient, because even though they appear comatose or unconscious, the hearing is the last sense that goes. And when I was administrator of a hospital, I used to have brain-injured people tell me who were in a coma. They could tell me exactly what the psychologist was doing his paperwork instead of talking to them or trying to do coma stimulation with them. And they lived to be able to talk and tell me what was happening in their sessions. So that is to say that even though a person appears non-responsive, they still may hear and comprehend, although they may not be able to converse with you. And that's a really bad mistake to make in front of a dying person. The other thing that families may not know if hospice is not involved is that the natural light from the window is a lot more receptive to a dying person than artificial light in terms of strong lamps or lighting in the house. We suggest that you get to know what the dying person is used to. For example, some elderly people do not want the television on day and night. You might be a person who can't stand the silence, but if you are taking care of a dying person, and you know that their mode of operation is quiet, and they're kind of, you know, we have to make sure that the environment's peaceful. So turn off the television if they don't want it. The other thing is that when you're dying, noise and confusion make it worse for the person. So if you have visitors for your dying person who want to come, and they and you notice that the patient is you know, reacting to the noise and the stimulation, it's perfectly fine to ask the visitor to limit their time of visiting the person, or to limit the visits. There'll come a time when the dying person will not want to be around people, and we'll go through some of that now. But all the stuff that I'm telling you is what the hospice people would counsel the family and make it more peaceful. Peaceful environment and quiet environment are usually what is best for the dying person. I can't stress how wonderful music therapy is to the dying. They absolutely love it. They have music therapists at the hospice that will come and play their guitar or their violins and whatever music the person wants, and it's so soothing. My mother, who was dying for 3 months, she was in so much pain, she didn't want to talk, and she, you know, wanted to be no stimulation. But the music therapy there would give her peace, or, you know, she liked the hymns, and we would play soft music for her. It's just as soothing to the dying person. I just can't tell you how important that is. So we have the nurse, we have the home health aide who will come up to 3 times a week, and they'll bathe the person. They will change the sheets. They will take care of the personal care needs of your loved ones. I think that Medicare will pay up to 3 times a week for that personal care. And then you have the social worker who will come once every 2 weeks. And the social worker's job is to see if the family needs anything, support system from the community. Like the dying person that we had in our home in April, I thought it was a great idea to get Veterans Administration involved because he was a veteran. And you know, I told the social worker, let's get that so that he can have a free burial, and you know, the cemetery is just opened. And Bill was on the porch one day, and I said, you know, Bill, I was just thinking that we need to talk to the social worker because you are a veteran and you can be buried in the Veterans Cemetery and in no cost or anything. And he exploded. Absolutely not, he said. He says, I've been homeless for 30, 40 years, and I want to be buried on the Woodville Highway where the rest of the homeless people are buried. And I said, but Bill, your people, all your friends can come see you. And he said, no, I want to be buried there. So I told the social worker, hold off, that Bill doesn't want that. But the social worker can refer you to different agencies in town that the dying person may need or the family may need. And they are skilled. They usually have a master's degree in counseling, and they're skilled in grief counseling. We see children who have their parents have died, one of their parents have died, and hospice will prepare grief counseling for the children left behind, as well as the spouses. But that's a social worker thing.
And then social workers also deal with setting up end-of-life issues with the family too, and if the will's not prepared and all this, they'll make sure the family takes care of all those issues.
Right. End-of-life issues is their specialty. And then the person never sees the physician. It used to be years ago that the doctor would come one time to do the evaluation, but what we're finding is that the nurse is the one who communicates to the doctor. The person never sees the hospice doctor. They are allowed to go to their personal care physicians if they can be transported, that kind of thing, but they're never, for some reason, never brought to the medical director of hospice. But they still are in consultation with their personal care physician. I think that was kind of strange, but that's how they do it.
Yeah, most hospices have a minister of some type too that's available.
Chaplain. In fact, Big Ben has a nun that lives at the Nauman Center, and but they have, I think, 5 or 6 chaplains. And that's the other thing that you have to respect. Like our Bill would not pray or didn't want any chaplain in. Others, they really need a chaplain. But the patient gets to say whether or not they'd like visits from chaplains. And like I say, for our Catholics, we have a Catholic nun who is a certified chaplain for hospice. They have to be very careful, to honor the wishes of people. I often say, well, Michael, if he could just talk to, the priest or a chaplain or somebody, but if they are adamant they don't want to, then we cannot have the chaplain come. The nurse and the social worker are really great about telling the family about symptoms of the approaching death. You'll notice that your loved one sleeps more, and sometimes they're hard to awaken, and they sometimes appear unresponsive. And remember what I said about the hearing, it doesn't mean that the brain's not working, it's just they're not able to respond. And usually when that happens, it's been our experience, within 2 weeks death will occur. And then disorientation. Towards the end, they may not recognize their lifetime friend that came to visit them. They just won't know who they are, or they'll be confused about where they are. My mom thought she was still in the hospital, and we kept her at home with the feeding tube, but they become very disoriented towards the end, and that's because, again, oxygen to the brain is not like it was. Usually they lose control of bowel and bladder, and sometimes the stomach extends because the bladder's not working, and at that point, when you see that, usually a catheter is put in to drain the urine. The thing that frightens people the most is the congestion, because of the metabolic changes in the body and not taking as much fluid. You'll hear the gurgling, and that means that that's another sign that death is near. What we do is turn the patient on their side and put a pillow to the back, and that helps it drain and makes it more comfortable. But it's really not painful or distressful for the patient, but it's awful it seems that way when the family sees that. But again, that's why I say hospice is so good in telling the family about, this is not painful, this is not how it seems.
That's another advantage, is that the last day or last 24 hours, the hospice can provide someone there. They'll be there all 24 hours.
It's wonderful for the family.
So if family members need a break from all and can't really take it, they can do that. Mm-hmm. And hospice will be there. That'll be the last 3 days.
They will become very restless, and they will tell you that they've seen people who have died years ago. It's not hallucination, it's just their way of beginning to be more comfortable with letting go. They'll see things that you don't see, and they hear voices that you don't hear, and that's because of metabolic changes too, and they're getting ready to make the transition. It is a mistake for families to say, you didn't, they've been dead 30 years and you didn't hear them, and that you don't argue with the dying person. It's real to them. They're telling you they saw grandmother. They see different places, and you don't argue with them about it. You just let it, just tell them that if it scares the patient, you tell them that this is normal, and it is most times.
My daughter.
Absolutely. Pardon me?
It's coming up on 10.
Oh my gosh. Okay. There's so much to say about it. But I think I've covered what hospice covers. I was just going over some of the signs of death, which, you know, it's great for families to be prepared because that time comes when you have to say goodbye. When you're ready and the patient is ready, it's the best time to say, we're going to be fine, because sometimes the patient will hang on because they're afraid of leaving the loved one that they're not going to be able to manage without them. And so we've had to do this many times and say, we're going to be okay. You go in peace. It's okay for you to leave us. And that gives the dying person permission to die. And when that doesn't happen, people tend to linger and be restless, but we always encourage the family to say their goodbyes when it's time, and the nurse will know when it's time, and say, allow this person to go.
Yeah.
And it's really very hard. 10 o'clock, we need to wrap it up. I could just go on all day, but I won't. Did you have any questions?
No, it's just, I mean,
It's overwhelming, isn't it?
It is, but it's good information.
Mm-hmm. Well, it's one of those things that we all have to go through. And if you know a little bit about what to expect, it makes it easier for the patient and for the family.
Yeah, it's just, you know, because in your mind you're going, okay, where is it assisted suicide versus palliative care, you know? And it's, you know, and I listen to Catholic radio and that question gets brought up and it's like...
Well, we're going to have a symposium in February the 18th, and we're going to be talking about those kind of things. Father Tom is going to give an in-service on what the church teaching is on choices at end of life. In fact, it's called an end of life seminar, symposium, and Father Tom will give the church's teaching on end of life issues, and then we're going to have Dr. Sheedy, the oncologist, talk about palliative care. We're going to have a very wonderful lady from hospice talk about the hospice care. We're going to have Paul Malley, who will talk about the 5 wishes, you know, how someone writes down what their wishes are. Just help the family and you know, how they want things to be. So we're going to have different aspects of the end of life, and it's going to be really a very wonderful symposium with experts in our area to talk about that. That's February the 18th. It's a Saturday. I think it's the 3rd Saturday of February.
What?
3rd Saturday of February. And it's going to be after Mass from 10 o'clock until 2.
Oh, okay.
And there'll be lunch provided, but it's an attempt of our church to give this information to many people who are struggling with terminal illness or have loved ones struggling with terminal illness. And I think it'll be worth everyone's time.